Welcome to Southeast Medical Group, Georgia's most awarded primary care provider. We're here for everyone, offering comprehensive care for all ages. Our services include annual checkups, chronic disease management, vaccinations and immunizations, women's and men's health services, pediatric care, geriatric care, and mental health support. With state-of-the-art facilities and a compassionate team of experts, we provide personalized care for you and your loved ones. Experience award-winning care today. Schedule your appointment now and see why we're Georgia's top choice for primary care. Southeast Medical Group, your health, our priority.
Hi, and welcome to HealthCast Southeast. I'm your host today, Dr. Jeff Stone, a family physician for 40 years, and we've got some special guests today. But what I'd like to talk about today is something that is a major change. We'll call it a significant paradigm shift in the medical industry. It's called value-based care, and we're transitioning from what's traditionally volume-based, fee-for-service models to systems that reward healthcare providers based on patient health outcomes. Think about that. The better you do, well, the better I do. Isn't that the way it should be? This paradigm shift emphasizes quality, efficiency, patient satisfaction, thereby necessitating an evolution in the approach to diagnostic services. Now, diagnostic services include things like laboratory tests, imaging studies, and other medical evaluations that play a crucial role in the success of value-based care. This episode explores the integration and the impact of diagnostic services in value-based care, highlighting their importance in improving patient outcomes, reducing costs, and enhancing the overall healthcare quality and your satisfaction. Let me try and put it in different terms. It goes something like this. If you had to purchase a product or a service, we'll say from Walmart, you'd walk in the store. You may ask for assistance, but basically you're on your own. You pick out that product or service, take it to the checkout counter, and you pay with whatever means you have. You take that service home. Well, in fee-for-service, or in the current medical industry, you'd go to that same retail store. You might get some help with hopefully a trusted person that would take you to the service or product you need, and you'd take it to the checkout counter. Well, at that point, you would pay a token amount, but the preponderance of that money that you need to pay for that service would be paid for by someone else, an insurance company or a share care, something like that. All right, so it's a leap to create this analogy, but I'd like to picture this. In value-based care, you're met at the door at this particular store. You're navigating through that store to find out just what you need and only what you need. That is to say, you won't be picking out things that you don't need, or if you want that other service, there'd be some shared decision-making about what you need to get the job done. You'd still go to the checkout counter. You'd still have a token fee to be paid. But at that checkout counter, the person checking you out would be paid better. The navigator would be paid better. Your outcomes would be paid better. And that payer that pays the preponderance of your bill, well, they would have to pay less because you're getting good value for whatever it is that you're getting. But wait, there's more. What if you didn't even have to go to that store at all? What if you could do a lot of this from your couch in your living room and still accomplish the same kind of quality outcome with lesser cost? Well, that's what the future is looking like. That's what Southeast Medical Group is working on right now. Now, your doctor can't do it all by themselves. We have behind-the-scene heroes, and we need them to help us with the diagnostics and with all the logistics and the costs that go with that. And I'd like to introduce our guest today to tell us how that's done. My special guest, Sam Park, welcome to HealthCast Southeast.
Thank you, Dr. Stone. Thanks for having me here.
It's my pleasure. Hey, Sam, tell us what brought you to Southeast Medical Group.
Yeah.
And if you could, maybe define your role in some way.
Sure, yeah. So not to bore you or your your audience about my background, but basically I started my career in the military. I was a combat medic in the U.S. Army. So I did a tour in Afghanistan and in Iraq with the Army. And when I got back, they asked me to get ready for a third tour. So at that point, I just couldn't hang anymore. And I was like, you know what? I need to do something else for my mental well-being.
That's awesome. And first of all, thank you for your service.
I appreciate it. Thank you. Yeah. Thank you. Yeah. So, but I still was a great experience for me in the Army. You know, I got a ton of experience, especially when we were deployed, just because of the fact that we basically had one doctor there, and we would have a mass casualty with 20, 30 patients at one time. And there was limited ability for the doctor to treat all those patients. And so us as medics, we got a lot of hands-on experience over there, of things that we couldn't do here in the States, obviously. But we were able to at least get a lot of good experience doing that, for better or worse.
Okay.
Yeah.
So was that, I guess, a stage to set you up for being the background, the backup, the ability to help providers and physicians to do their job? Absolutely.
And obviously, I got firsthand knowledge of what a provider has to go through, what a doctor has to go through. But also, I realized that, like you were saying, they can't do it on their own. You know, with that one doctor by himself, there was no way that we can get to all those patients. And so I saw the need for people like what I'm doing now, or all the support people in the background that usually patients don't see, right? So when people think about healthcare, people think about usually the doctor or maybe like a nurse, and that's really about it. But there's thousands and thousands of people. In fact, I think there's more of the support team than the medical team in some ways.
More administrative than ever before.
Right. Absolutely.
And sometimes that's looked upon as a little bit of a negative, isn't it?
Sure, it is, absolutely. But, you know, obviously, and I think we'll talk about it as we go through the podcast, but the way that the healthcare is transitioning, I do think that there is a need for the administrative staff, maybe not more of them, but just more, I guess, the work that you have to do in the background to help support the providers.
Well, you're well experienced in this too, but maybe it's affected you in other ways on a personal basis. I think you told me off camera that there was a story, an anecdote, if you will, that sort of epitomized your view as a consumer of the medical.
Yeah, absolutely. So in many ways, I think of the way that we're transitioning healthcare, equivalent that to a movie called Moneyball. I don't know if you've ever seen that movie. Great movie about baseball, but it's about the 2002 Oakland A's, based on a true story about their team, that prior to that year, they were a terrible team, always with very low money to work with to get the best players. And so they brought in this statistics guy. And instead of the traditional baseball model is that scouts would go out there and watch a baseball player swing the bat 1,000 times to see what their stance is, their hand-to-eye coordination, all those kinds of, or even like a pitcher's speed of his pitches and things like that. Well, Moneyball, or the story in Moneyball is that basically instead of using scouts, they basically are using statistics such as on-base percentage, slugging percentage, which is how many bases the player averages per bat. So using data like that, they built this team with bottom dollar players and turned it into a successful team. They won 103 games. They hit a 20-game win streak, which was a record at the time. They didn't do well in the postseason, but still, that model was so successful at the time that today, if you look at baseball the way that it's run today, it's all the teams are using statistics to some format. Even the ones that have all the money in the world, they will all use statistics to build their team. And in many ways, I feel like that's where our healthcare is headed. And I think it's mostly positive. I think some of I want to say old school providers may look down upon some of the changes that are going on. But I think overall, it would be a positive change, especially for the patient outcomes.
Okay. So besides the fact that you may play some role that looks something like Brad Pitt.
Yeah.
How do you generate these statistics? This data, these metrics?
Yeah, I don't look anything like Brad Pitt, unfortunately, but yeah. So there's a couple of references that we work with, such as the United States Preventive Services Task Force, or USPSTF. Basically, it's a database where it tells you, it gives you providers, especially healthcare providers, an idea of what kind of preventive services that we should be doing on patients that meet a certain diagnosis or meet certain conditions. And it's all based on thousands of, or maybe not thousands, but a lot of data of healthcare outcomes from the past. And using that data, they've built this this task force or this guide for healthcare providers to use.
Yeah. So obviously, a good, accurate, precise diagnosis leads to better outcomes, hopefully better patient and provider satisfaction.
Yep.
Any anecdotes about that? Any personal stories there?
Yeah. So, I mean, I think of this one time, a few years ago, I was in a major car accident. And I went to the ER. And before I even saw anybody in a white coat, they had me do several different imaging studies, several different x-rays, CTs, MRIs, etc. And I asked the person at the time, like, do we really need to do all these tests? And they told me it's their company or their hospital policy that basically that anybody that comes in with, let's say, car accident, they have to go through a litany of tests. And I can, from the ER perspective, I can maybe see that, understand that. But the problem is that outpatient organizations, healthcare organizations are kind of copying that model in the fee-for-service world, where essentially we're blanket testing patients for condition or for tests that they may not even need.
Right. The more they do, though, the more they get paid.
And that's the problem with the fee-for-service model, is that doctors or healthcare organizations but they benefit from higher volume of testing. So the more of these CTs, X-rays, et cetera, that they do, the better it is for them. And, I don't think that all doctors are out there, to make money and just get all these tests done. But it does kind of give that incentive, even whether subconsciously or not, to kind of do more additional testing that maybe the patient may not need.
And there may be other pressures on them, like medical legal.
For sure.
To follow an algorithm that will not only make them more money, but avoid any kind of liability, that they miss something else too.
For sure.
All right. Well, how do we get to target somebody with the data forensics that are just right for them? I think you mentioned the USPS Health Task Force.
Yeah.
I know that there are other ways that you can get that, but inevitably it comes to testing the individual. How do we know what test is right for you? What are your thoughts on that?
Yeah, so in one way, we can start with some of the measures that healthcare insurance carriers kind of, I don't want to say mandate, but they kind of require us to do for a lot of our patients. As an example, if a patient has diabetes, health insurance carriers want us to do an annual diabetic eye screening on them. And that is a measure that all providers have to meet. And so for better or worse, the provider is kind of graded on how many of their patients get this test done every year. Similarly, with certain medications, I know there was a controversy kind of the insurance carriers kind of mandating all patients with diabetes beyond like a statin medication. And that's like a measure that they're measured for. So things like that we start there with requirements that the insurances have on us, and we test the patients on.
And just to clarify too, unlike the providers that are testing and getting paid for it, the insurance company is disincentivized to spend money. So if they're asking for these tests,
yes,
it must be something that in the long run will save them money and create better outcomes.
Yeah, you're absolutely right. So yeah, I want to clarify that for sure, that instead of us saying, we pay a doctor or pay a healthcare organization for doing these tests, basically health insurance carriers who, like you said, they want to save money and they want us to limit the testing that we're doing. They give us a list of patients that meet certain criteria, whether it be diabetes or high cholesterol or different conditions that the patients meet. And based on those conditions, they want us to make sure that those patients get tested. So in a way, it's better for the patient. It's more targeted. It's more personalized for them, rather than it being, okay, it's a patient, maybe no complaints, they come in and get an EKG and X-ray on them. Instead of that happening to them, it's certain patients that really need those services done, need that diagnostic service done, that get that service.
Yeah, so I can see where in the industry there's this tug of war going on between the insurance company and the providers in fee-for-service that are always antithetical to each other. They're incentivized in exactly the opposite ways.
For sure.
So how does value-based care change all that?
That's a hard question, actually. But value-based care, because value-based care is very, it's much more data-driven, like we were discussing. And so instead of us, a doctor just saying, we've got a list of 10 patients and just go ahead and test all these patients for it, that we're using that data to target, okay, out of these 10 patients, there's 4 that we need to get these services done. And so it limits the amount of testing that we have to do, the cost on the patient and on the healthcare system as a whole. And so from that point of view, I think it limits the cost on the healthcare industry overall.
Okay, let's start with some examples.
Okay. Yeah.
Okay, because I know you're in charge of a lot of these diagnostic services. Give us a couple of examples that are good for the long run, even though the insurance company and even the provider might suggest that this is the right thing to do right now.
You mean like specific diagnostic services? Yeah. So a couple of services that we're really promoting right now. One is sleep studies. If people watched the podcast before, there's a commercial that I do where I basically try to promote sleep studies. But one of the reasons for promoting sleep studies is that something like 20% of the U.S. adults have sleep apnea, and 80-90% of them may not even know that they have it. And that's a lot of times is because snoring is such a common thing that I think a lot of adults struggle with. Yeah, exactly. Yeah. Your spouse snores, like, oh, I couldn't sleep that night because my spouse was snoring. Right. But snoring, not that snoring is equivalent to sleep apnea, but many patients that snore do have sleep apnea, and therefore,
why is that bad?
Well, because sleep apnea, basically sleep apnea is the idea of you stopping breathing at night, and therefore, if you stop breathing for a certain period of time, your body gets less oxygen. Your organs that constantly need a supply of oxygen, it's not getting the oxygen supply it needs while you sleep, and that's a third of your day. So for most people that they sleep, 6 to 8 hours a day, it's a third of your day. And that's a third of the time of your life that your organs are not getting the proper oxygen that they need. And so what happens with that in the long term, if you don't treat for sleep apnea, your organs start to fail. So I can give an example of my mom who she's currently in her 70s, but in her 30s she was snoring very loud. I remember that. And she wasn't diagnosed with sleep apnea until she was in her 60s. And during that time period, her kidneys got damaged. And so now she's on 5 or 6 different blood pressure medications. And after being put on treatment for sleep apnea, she took one of those medications off. She was able to decrease her blood pressure just by getting treatment for sleep apnea. So from that standpoint, I think sleep apnea is important for us to identify.
And how do you target that audience then? Do we wait for anybody to tell us that, golly, you've been snoring a lot? Do we go by weight, body mass index?
Sure.
How do we target that audience?
Yeah, that's a great question. So there are a couple of different questionnaires out there. One that we use is called the Stop Bang questionnaire, STOPBANG. It's an acronym for S for snoring, T for being excessively tired, O for any obstruction while you're sleeping, P for blood pressure. Let's see if I remember all that. B for body mass index, A for age, N for neck circumference, and G for gender. And based on the answers to the Stop Bang questionnaire, if any patient it says yes on 3 or more of the 8 questions on the Stop Bang, they technically are, at least from insurance standards, qualify for the sleep study.
Yeah. And you don't have to see a doctor for that.
No, absolutely.
It comes to you in the mail in a questionnaire. Absolutely. It could be on the patient portal if you've got an electronic health record.
Yes,
there are all sorts of ways to do that. And maybe others not unlike that.
Absolutely, yeah. So a lot of our clinics, I think they do it as part of the check-in process. So the initial kind of paperwork that all patients have to go through, there's an extra one. It's only 8 questions, so it's really short and very simple for patients to understand. So we add that as part of the check-in process. And so we were able to screen the patient. So you mentioned weight. My mom is like less than 100 pounds. And so in the past, I think there was a lot of people who kind of equated sleep apnea with being overweight. But that, as time has progressed, we've realized that that's not necessarily the case, that I myself have sleep apnea. There's people that are not overweight that may have sleep apnea still. Did you know that over 80% of Americans in the US may have sleep apnea, but not even know it. Some of you may have heard from your family member or a spouse that you snore at night, or you stop breathing for a short time at night. These could be signs of sleep apnea. And sleep apnea, left untreated, can lead to more chronic conditions, such as high blood pressure, diabetes, and other more severe diseases. So, what can you do? You can talk to your provider about getting a home sleep test. This test is done in the comfort of your own home and bed. All you need to do is sleep with a small device on your forehead, and your provider can review your results in about 48 hours. Come see us at Southeast Medical Group, where each of our clinics is equipped to order a home sleep test for you.
So I understand that weight is not the only thing, but one other statistic that our audience might want to know is that 60% of all people with a body mass index of over 36, you may have to look that up, do have sleep apnea. So it's a very common problem, and we can't always just target them by stepping on a scale.
Absolutely, yeah.
There are other populations that we want to target too, and I think some kind of go without saying, and that may be the colonoscopy now that's become fairly routine. We could go back even further, and blood pressure has been checked, well, indefinitely, back to the 1960s by most standards. That's older than you are. So what are some other studies that we do that we target and are important to our audience? And maybe what's some of that shared decision-making that go into choosing these tests, if you know what I mean? I'm thinking specifically about screening for colorectal cancer.
So you brought up colonoscopy, which is a great one. So obviously, historically, the only options that patients had available to them is the actual colonoscopy, where they have to go through a prep process, and then they have to obviously clear their bowels. They have to be put to sleep, put under anesthesia, and go through a really uncomfortable process of having to be screened for.
I've done it several times.
Once myself, and I didn't like it either. But you have pretty much had to do that every 5 years for certain patients, 3 years for other patients. And so there has been new technology that's been out.
Tell us about it.
So one's called Cologuard. Cologuard is a DNA-based testing. Basically, the idea is that when you have a bowel movement, your stool brings certain DNA along with it when it comes out.
Sure.
And so and they're able to use the DNA that comes out to test for colon cancer. And the studies have shown it's anywhere from about 93 to 94% effective at diagnosing colon cancer, which is, I think even regular colonoscopies are about 95%. So it's very equivalent to that, or at least very, very similar to the kind of the quality that you would get from the study. And so it doesn't really require a prep. I mean, it's done in the comfort of your home. A kit is sent to the patient. Basically, they put it on their toilet, have a bowel movement, put it back together, and send it back, and you're done. And so that makes this service makes it so much easier. It removes that barrier that patients had before of having to go through that entire unpleasant process. And there are several examples like that out there, but I think Cologuard is probably the best one out there.
And even if you don't do Cologuard, because there are some insurances that are either reticent to that or just don't pay for that, is there anything else that you can do in the comfort of your own home?
Yes, so I think there's a test called the FIT test. I'm not as familiar with it, but it's very similar in ways to the Cologuard that's available to them. There's also, it's much simpler, but obviously if you have colon cancer, a lot of times you have blood come out through your stool. And
we
that
can
blood
poop here. It's
poop. But obviously sometimes the blood is not always visible in your poop, right? So it's hard to tell if there's blood there. And so there's a little kit that you can get from the doctor's office called the FOBT. I forgot what it stands for. I'm sure you know what it stands for.
Fecal blood test.
That's fecal blood test. Yes. So basically, the patient can use a little stick to smear some poop on it, and the office can use some chemicals to test if there's any blood in the stool. So that's a very simple way to test. Obviously, it's limited, right? So because there could be other reasons for blood in your stool, whether it be from hemorrhoids or other kind of conditions. But at least it's an initial way to see, maybe is there something going on that we need to check.
And it sounds like we've got a menu of things that we can select from. And this menu is something that you can discuss with your provider, your physician, that fits you best, that is the most cost-effective and qualitative test to get to goal, which is inevitably to prolong your life and avoid having a cancer or diagnosing it early enough that you can do something about it.
Yeah, absolutely. Because all those things that we talked about have different levels of costs, different levels of prep times, and all the other barriers that come along with colonoscopies. And so you're absolutely right. I mean, depending on what the patient is able to do from both a cost and from a prep standpoint, there's a lot of options out there for the patients to get tested.
This virtual store that I was setting you up with in the introduction is also including other menu items as well, too. I'm going to allow you to move in that direction as well, too. So besides screening for colorectal cancer, there are other things that we can do from the comfort of our own home now.
Yeah, absolutely.
Talking about RPM or remote patient monitoring. Can you tell us something about that?
Yeah, so RPM is it's a relatively new a new kind of thing in the healthcare industry, but it's a huge and important part of the healthcare industry. And the reason why, basically RPM, remote patient monitoring, is a way for providers to, it's in the term, really monitor the patient remotely on multiple levels, from pulse oximetry, weight, blood pressure, all of these things that the patient can have at their home, like historically, as you know, as a provider. If I'm a patient with blood pressure issues, or if I'm a patient with diabetes issues, you're relying on me to fill out a journal every day, in essence, and say, this was my glucose level, or this was my blood pressure level. And as you probably know, patients aren't very good at doing that, unfortunately.
Reliability, I think is what you're talking about. Okay.
Absolutely, yeah. So what RPM does is it removes that barrier, where basically there is now a device in the patient's home that they can put on at certain times of the day. Certain devices are on them 24/7, but we can use the current technologies that we have, whether it be Wi-Fi, Bluetooth, the NFC technologies that are in our phones, the LTE technology that allows us self-service. People use those technologies now and put them into devices like a blood pressure monitor or a glucometer, and we're able to transfer that information from the patient's home, where they do these testings, to that provider's desk. And therefore, we now have an ability to monitor that patient much more closely, much more accurately, not depending on them have to fill out a manual journal that they probably filled out in the car before they came in to see you, So
yeah, and how reliable is that?
Exactly. So that from that standpoint, it's going to revolutionize healthcare, I think, in a lot of ways, that allows us to treat these patients for conditions that from their home, rather than patients having to come in all the time to do that.
Right. And again, we're targeting a population that needs it the most, but not anyone that doesn't need it. Is there anything that we don't need to do? Is there an audience that maybe gets either too much testing or shouldn't be tested? Any examples?
Yeah, there's a couple of examples I think that are kind of widespread. I think the use of EKGs has been known to be kind of widespread, in the sense that a lot of patients may not need an EKG, and the doctors kind of order that kind of like a routine test for all patients. You're getting an annual physical, get an EKG. Chest X-ray is another example of that, where patient may not have any symptoms whatsoever. They may be in their 20s, and they're getting, it's not a lot, but it's still a dose of radiation when they take that chest X-ray for no reason. Routine mammograms for males. I think there were some healthcare organizations that were promoting that. I think there's very, very small numbers, something like 2,400 males that have breast cancer throughout in a year. So I mean, a very, very small percentage, and to kind of do widespread routine mammogram testing on male patients for such a small number, that's probably not the right thing to do in the healthcare system.
Yeah. Classic example.
Yeah.
Well, too. Yeah. Okay.
Hey, HealthCast Southeast is proud to bring you our presentations, and we'd like to bring you more. Now we need to know what you want. I hope you've enjoyed the episodes that you've seen so far, and to that end we have a QR scan code that's on the screen. Please take the time, if you will, to complete that. Give us the feedback, and we'll send you what you want. We're looking forward to more episodes, just like the ones that you've seen. And for now, have a great day.
Well, with all that data then pouring into the office of the doctor, I'm still thinking of all the gigabytes that I as a physician have to process. What other pathways will that go? Are there any other organizations, or I'll call protocols, and I'll throw it out there, my own answer, chronic care management teams that can handle all that? How do they do it?
Yes.
What's your role in that too?
Absolutely. So we were talking about earlier, kind of like the background people in healthcare, right? The people that the patients may not see, but they're there doing important work. And CCM team is one of them. The CCM, or chronic care management, is basically a team of, they're either medical assistants, pharmacy techs, nurses, some sort of medical background. And they are constantly reaching out to patients at least once a month, or sometimes multiple times a month. And the kind of work they do is almost hard to describe, in the sense it's very widespread. It's everything from asking and making sure that the patient's taking their medications correctly. If, let's say, the last doctor's visit, the doctor gave certain orders to the patient that, I want you to do these things before the next time you come in, the CCM team is able to go in, look at that patient's record, read that note, and say, hey, the last time you talked and met with Dr. Stone, he asked you to do these things. Are you abiding by them? Or what can we do to help you abide by those orders? So the CCM team is going to be, it's been around for maybe about 5-6 years now, or maybe a little bit more, but it's really picked up, and I think it's going to expand further. So one example I can give. So I used to work for a doctor in California. Basically, California is much more, they've moved much more towards a value-based care system than we are here in the state of Georgia. And, obviously in a fee-for-service model, you're going to want to see 30, 40 patients a day. It's you're seeing a volume of visits in a day. The doctors in California now, they're seeing 3, 4, maybe 5 patients in a day. They're able to spend an hour with that patient if they need to.
Because they're at higher risk. They're targeted people.
Exactly right. So, and that's exactly the point, is that right now in the fee-for-service model, patients are kind of set to whether 20 or 30-minute schedules, regardless of their condition, right? So you can have a patient who is completely healthy, young and healthy patient, no major issues. They're set for a 20-minute visit, whereas another patient who's got a litany of issues, hypertension, diabetes, hyperlipidemia, and previous history of cancer, and they still have that same 20-minute block as that young patient with no condition.
Not efficient, really.
Absolutely not. And so the value-based care system helps in that regard by allowing providers more time to talk with the patients. And going back to what we were talking about earlier with the CCM team, that's kind of what the doctors are able to do, is use the efficiency of the CCM team, of what they can do on a day-to-day basis, so that the patients may not have to come to the doctor's office every month or every 3 months or whatever it is, that we're still communicating directly with the patient through both the CCM and through the RPM, remote patient monitoring, that we do.
Yep.
And so we also have like telehealth visits now available to patients as well. So multiple ways that we can address healthcare needs for that patient without them having to constantly come in and see the provider.
On the surface, it sounds really good too, but as you were speaking, I was wondering how many people out there are thinking, this is a little bit creepy. You mean all of my vital signs are going to my doctor's office?
Yeah.
People are going to be calling me because I get 10 spam calls a day anyway.
Oh, goodness.
How do we get beyond that?
Yeah.
I'm not saying there's an easy answer here too, because there's some people that can opt out of this system.
Of course. Absolutely, yes, of course. And patients certainly have that ability to opt out. But it is a difficult barrier, especially in today's age where, everybody gets spam calls. There's a risk of frauds, of people calling in from your bank's phone number, but then it not being your bank. So it's definitely, and the sad part is that a lot of that targets the elderly population that may not be as familiar with some of the fraud events that are going on right now. And so I wholeheartedly agree with some of these patients that they don't answer our calls. And so we to kind of combat that, we do use multiple avenues of communication. So first we try to send a text and say, hey, Mr. Miss So-and-so, this is your CCM team from Dr. Stone. Reaching out to you, just wanted you to have my number. Please feel free to call us here at any time.
And I do try and tell them,
Yeah.
Sam will be calling.
Yeah, exactly.
His team will be calling.
Right.
Doesn't always work though.
Yeah. It is hard. That's probably the biggest problem that we have with both the CCM and the RPM team is that communication with that patient. We do have to somehow reach out to that patient once a month to kind of make sure that all the diagnostic tests or diagnostics that they need to be tested for are being done.
Yep.
But sometimes we're just unable to reach them.
And maybe the technologies will catch up with that too.
Yeah, I hope so.
With more secure lines, either through the portal of your electronic health record, or something again that might be equivalent to my Apple Watch or an identified Fitbit.
Yeah, I think there's a lot of smart people working on it. So I'm hopeful that we'll find some kind of solution to it. Because that's honestly right now, even from our organization, I think about 40% of our calls are we're not able to reach the patient.
Any advice on how to address that on the patient side?
Yeah.
In other words, they're listening to this. They're thinking,
for sure,
I want this. I want my doc to be a part of my healthcare plan.
Yeah.
As often as it takes to keep me healthy.
Yeah.
But how do I know that you're not a fraud?
Yeah, I think the first thing, the best advice I can give to patients that are worried about that is that even if you don't answer a call, if there's a missed number, try calling that number back. So I gave the example of a bank earlier. Yes, they can spoof the number of the bank when they call you, but when you call that number, you're for sure getting that bank. They can't spoof that part. And so you can know for sure, you can rest assured that if you as the patient call that number, that the person that you're talking to is who you intend to be talking to. And so one of the ways that we can maybe help this is that we can maybe give the number of the CCM caller to the provider, and they can provide it to that patient, and they can maybe have that number to call if they would rather do it that way. But we also, we'll leave a message, we'll send a text message, and that way the patient can call back to that number and rest assured it's not going to be a fraud.
No, they won't. And the people will know them on the other end.
Right, exactly,
We'll have said, yes, here's your whatever numbers you need to verify that you are who you say you are.
Right.
All right. Well, that sounds good. I think it's a little too early to summarize, but this is looking really good on paper. Are there any questions that I haven't asked that I should have asked you?
Let's see. Put me on the spot there.
I do. This is spontaneous.
Yeah. I don't think that I have any questions. Let's see. Huh.
So in the realm of value-based care, to achieve that goal, we need folks like you in the background, in concert with their providers, their doctors, their physician's assistants, their nurse practitioners, trying to get as much data on you as it takes to target those at risk, and then give you the right therapy at the right time with the right costs to accomplish the end game, which is a better quality of life, a better length of life.
Absolutely, yeah.
And that's value-based care. And in the end, the provider gets a little bit more money for it. The patient's premiums could at least go down or remain stable in an era when every year our premiums keep going up. The payers, who are the insurance companies, will be spending less because we're not doing volume-based testing. It's targeted, tailored testing.
Right.
And so they do better. Is there anybody that loses in this system?
Yeah, that's a great question. I can't think of anybody that's actually a loser in a sense.
Yeah.
I think from multiple levels, from the healthcare from the insurance carrier, obviously they save. If we limit the amount of testing that we do for unnecessary tests, the provider, obviously with better outcomes of the patient, gets a benefit from it. The patient, as like you said, it's much more tailored or targeted diagnostics or diagnostic service that patient gets. Not only for their healthcare outcomes, but for their out-of-pocket costs. For those patients who have like a shared program where they're paying some part of their healthcare, whether it be deductibles, co-insurance, and co-pays. Yep. You limit those costs to that patient as well. So from those factors, I think all of those teams benefit from the transition to value-based care, which is why we're, as an organization of Southeast Medical Group, why we're such a gung-ho on this, and we're really trying to push that change. Right now, I think if you're a patient for a Southeast Medical Group, you may feel like there, I don't want to say disarray, but you may sometimes feel like there's a little bit of a disarray right now. And there's a reason for that. And that's because there's a transition phase right now of roughly about 12 to 18 months that all organizations have to go through when they transition from fee-for-service to value-based care. And the reason why it's such a difficult time right now for us and our patients really is that we essentially have to do double work. We have to do the work of the fee-for-service, meaning see the high number of patients that we see every day, while also preparing for what we need to prepare for when we're on value-based care system. And so because we're in that in-between stage,
Messy middle, I like to call it.
Yeah, absolutely. Yeah. And it's just, it puts a lot of burden on not just providers and patients, but on the admin team behind. And we're trying to do our best, and it's really on us to help remove that burden or to kind of relieve that burden from the providers. Whether we're doing a good job, I don't know, but we're trying our best. And
yes.
And that's why I think the admin team is growing in a sense that we need more of us to help remove those kinds of burdens and things like that from the providers.
Yeah, I think that time period too. I think you mentioned that you thought maybe 12 to 18 months, that sort of thing. Yeah. May take a little less or a little bit more. It just depends on how well we can make that change management effective, get the vendors, the services in place, get our patients healthy, and document all of that so that the payers are on board with us at the same time.
Yeah, absolutely.
The subtleties of everything that we're doing. It's a tall order, but we know that other models have worked. Other countries have used this.
Sure.
It won't be long before we're at the top of that heap as well.
Yeah, absolutely. And it's I think it's a necessity, as I'm sure you and the audience all knows. U.S. healthcare costs are higher than any other organized country in the world.
With lower quality.
With lower quality, lower outcomes. We have the poorest outcomes of all the, I think it's called wealthy countries in the world, or whatever it is. Out of all of them, we're lowest outcomes as far as chronic conditions for adults, life expectancy, and things like that. And so we really want to, I think, changing towards value-based care really aligns the goals of the patient, the provider, and the healthcare system to really bring down those costs and improve outcomes. So we're very hopeful, and we're very we are kind of at the forefront of that here in Georgia from the primary care standpoint. And so that's why we really promote our company, and we really want our patients to come to us more than any other organization, just because of the fact that this is what we're preparing for, and not a lot of primary care doctors are thinking about that.
Right. Yeah. And we've got a long way to go even beyond that, too. I'll offer up this, that even after we get remote patient monitoring, targeted diagnostics in the right place, in the right hands at the right time, that there are still things that are impediments to good health. Education, transportation, nutrition. We're talking about, these social determinants of health that may require our creativity and innovation to reach out to the community. Go beyond the providers themselves. I can't drive my patients to and from my office, but Sam and folks like you are going to be able to come up with plans to do just that, so that the health of the entire community gets better.
That's absolutely correct.
That kind of diagnostic and supportive services.
Absolutely, and that is a thing that we're actually working on as an organization already, social determinants of health that you mentioned. So for the people who are listening, as an example out there, there's, everybody's going through a hard time in today's economy, and some patients are having a hard time deciding whether to buy food or buy their medications. And that is where organizations like us, value-based care systems, the CCM team that we mentioned earlier, that's where we can play a role in that, where if a patient is having to decide to, between their medications and their food, there's things that we can do. There's programs out there that we can use to help that patient and get the medications that they need at no cost to them. And so there are more, that side of the healthcare industry, I think, is growing more and more, where we're able to reach out to the patients for things like transportation. Previously, I think that was almost like a compliance issue where, we were unable to pick up a patient and bring them to a healthcare, to their doctor for compliance reasons. And I think that mindset has changed a lot. And I think as patients, I'm hopeful, as a patient myself as well, and I'm hopeful that those things are changing for the future, is for the better.
Your enthusiasm is infectious. Your optimism is also. So I can't wait to get there, and I know it's a journey we're taking together. And I want to thank you very much for being a guest on this podcast. It's been absolutely invaluable. And I can't wait to bring you back maybe in 6 months, a year, and see how close we are. Not only what might be considered complete value-based care, at least a whole lot of steps closer to that, with patients that are happy, payers that are happy, providers that are happy as well, too.
Yeah, that'd be very exciting for us to see where we've gotten to, maybe in 6 months, 12 months, and kind of look back at what we discussed today, and I'd be really excited to do that. So thank you so much for having me.
Thank you.
Appreciate it.
It's been a pleasure.
Thank you.
Well, thank you for attending our podcast on the transformation of healthcare. This paradigm shift is going to affect us all, but in a positive way, and we're working hard to get it that way at Southeast Medical Group. I'd like to look forward to future podcasts with you. Again, if you have any suggestions, we'd love to hear them from you. And for now, have a great day. Bye.